Hey Sarah, how are you?
Good, how are you?
Good. Today we're going to talk about the physical examination of the knee. The exam, of course, starts with the history. That's going to be the most important part of the evaluation. So we've already talked to Sarah and gotten the entire history on her knee, and now we're going to go through the exam. Perhaps the hardest thing to do is to have the discipline to not just start examining the patient up on the table, because you typically come into the room and the patient's already seated and you have your conversation. It's an easy thing to do to start wanting to examine her. Sarah, can I get you to stand down here? Let me get you first to stand right here. We'll take a look at your legs, and then I'm going to take you out in the hallway and see you walk. All right, just put your feet a little closer together. Look straight forward at me. Okay, not the knees. That's it. Just a little bit apart. That looks good. So what we're doing is we're looking at Sarah's overall alignment. We're looking at the fact that her knees are almost touching, her ankles are just a little bit apart, and we're looking at the way her feet roll. Can I just slip your shoes off too? All right, so we can see the alignment of her feet. Now let me get you to turn around, Sarah. Put your back to me. What I'm going to do is I'm going to gently feel your hips, Sarah. It won't tickle you a little bit here. I'm going to feel for the top of her iliac crest so I can see that she stands with the legs at level. I'm looking at the overall alignment and looking at the alignment of the feet. All right, Sarah, let me get you to come out in the hallway next. Come on out here. Let's just start right here. Okay, just walk about 10 steps. Just walk the way you normally do. That's it. So we're looking at her overall gait. We're looking at her shoulders, seeing whether they're swaying side to side. We're watching her feet. Sarah, come back down to here, and then I'm going to have you do it again. Okay, the feet go back and forth. We're looking at the cadence. Go ahead, turn around. We're looking that she spends equal amounts of time on both legs. Go ahead. She's bending the knees. She's clearing her feet very nicely, and she has good alignment of her feet. She's not rolling excessively. Turn around. Come back one more time. Excellent. Okay. I think you should hop back up on the table for me. Sarah, can I next get you to put your feet up this way for me? Just stay seated though. So you've been telling me about this right knee bothering you. Can you show me where your knee hurts you?
Right here.
That's the spot right there. It's bugging you, huh? Okay. Sarah, you said your knee hurts everywhere. Can you show me what you mean?
It feels really bad right around here.
Okay, very good. All right, Sarah, next thing I'm going to do is get you to lay your head back. That's it, good. I'm going to look for any swelling in the knee joint. So I'm looking for any evidence of fusion or swelling in the joint. And the best place to look is over in the medial recess here. I think you can just see she's got a little bit of a hollow there. What I'm going to do is I'm going to be sure there's no fluid in that recess. I'm going to milk the fluid out if there were any. And then I'm going to bring my hands from above and below and from the lateral side. And if there were any effusion, any joint fluid, it would show up right in this spot. We'd be able to see it. Now she has no effusion in her joint, but that's where we would look. Come from above and below and the lateral side, and you'd see it right in here. Okay, now that I've got her nice and relaxed, I'm going to start with the patellar exam. I'm going to go back and forth. I'm going to gently feel the kneecap moving in the groove, get a sense as to whether there's any rough cartilage. Now I don't want to do it way high up above the groove. If anything, I'm going to move it down gently in the groove. I'm going to feel the knee move back and forth. And I can tell that there's no roughness to the undersurface of the kneecap. I'm going to pull the kneecap over to the edge a little bit, feel for any tenderness along the outside edge of the kneecap. Then I'm going to feel right at the bottom pole of the patella, right here with my index finger. I'm taking my left hand, pushing the kneecap up just a little bit, and pushing right at the inferior pole of the patella. Then I'm going to feel down here at the tibial tuberosity, where you might see an Osgood-Schlatter disease. We're going to also, while we're looking at the patella, we're also going to look at the alignment of the limb. So I'm going to draw an imaginary line down from the anterior superior iliac spine, down the line of the quadriceps. And that's going to come into the kneecap. And then I'm going to feel for that tibial tuberosity. And I'm going to have an idea of the line here compared to the line here. So the pull of the quadriceps versus the pull of the patellar tendon. Now, if you move the patella over, everyone will be straight. The trick is you have to put the kneecap, the patella, right in the center. So I'm feeling the medial and lateral sides of the femoral condyles here with my index finger and thumb. And then I'm taking the kneecap right in the middle. And then I'm feeling here with my other hand, the index. I'm looking where that patella sits relative to the tibial tuberosity. And in Sarah's case, the alignment looks good. The angle looks normal. It's about 12-15 degrees. And the alignment medial to lateral looks good. So if I divided the kneecap in half and then into quarters, I would look at the tuberosity and say it's roughly underneath the third quadrant or the third quarter. 1, 2, 3, 4, and her tibial tuberosity lies pretty much beneath the third. If someone has severe malalignment, then they might be sitting over here or perhaps even way over here with the tibial tuberosity. So her alignment looks good. Next, we're going to test for range of motion. So I'm going to start with the range of motion by checking her extension. I'm going to gently hold the thigh down with my left hand, and I'm going to lift her heel up off the table. And you can see that she comes up about a centimeter or so, and then I'll compare it to the other side, and she really has basically the same motion. So she has just a tiny bit of hyperextension. You get a test her flexion. Does that hurt you? Does that hurt? You can see she comes all the way up. In this case, her heel comes all the way up to her butt. All right. While I'm at it, I'm going to check for hip motion. So I'm going to inwardly rotate the hip and outwardly rotate the hip. Often hip problems or hip pain can be referred to the knee. We want to be sure we're not missing some problem up the hip. And of course, we're going to compare the two sides. Okay? The key to the ligament exam is to get the knee to relax enough. I'm going to get her to roll back and forth just to start to relax the muscle. I'm going to reach in with my upper hand and I'm going to hold on to the medial side of the hamstrings right here. With my fingertips I can feel if she's tensing up. Roll her back and forth to get her to relax. Flex the knee about 15 degrees. I've got that upper hand feeling for the hamstrings. My lower hand is going to come to the upper part of the tibia and I'm going to gently pull forward. Sort of a rocking motion. Holding this hand above, this hand below. I'm going to pull forward like this, and I'm going to feel for the ACL tightening. The ACL ought to feel like a cord or a rope. The ACL should feel like a cord or rope, and so I'm pulling it. I should feel that sudden stop at the end. That's what it should feel like. What it should not feel like is it shouldn't feel like this. It shouldn't feel soft and springy. That's a torn ACL if all you feel is it getting tight as you get to the end. You ought to feel this tight cord-like structure stopping like that. So we've examined for the anterior cruciate ligament. Next we're going to test the collateral ligaments. Medial collateral ligament, lateral collateral ligament. So again, getting the leg in a relaxed position, knee flexed about 30 degrees, I'm going to take and gently apply a valgus force. Got my hand supporting the legs, I can feel the hamstring, my lower hand down on the foot, and I just gently apply a valgus stress. And what I should feel again is I should feel the MCL, the medial collateral ligament, getting tight. Again, it should feel like a firm cord and not just a lax foam cord. Then I'll just reach my hand over to the medial side and I'll apply a varus stress. So I'm now taking the foot and pushing in a varus mode, and I'm testing the lateral collateral ligaments. Again with the knee flex 15 degrees. Again with the knee flex 15 degrees. I'm putting a varus load and I'm feeling for the lateral collateral ligaments. Next I'm going to test for the posterior cruciate ligament, and there's really two ways to do that. Perhaps the easiest is to bring the knee up to 90 degrees and apply a posterior stress. Push down like this. If it's abnormal, you'll see a hollow here. Normally the tibial tuberosity should be above the end of the kneecap, above the patella, and if you see it scooped out, that's an abnormal sign. Then I'll show you the posterior drawer test. I'm going to put the knee at about 90 degrees. I'm going to gently put my foot to my thigh to stabilize it. I'm not hurting her toes. Now same thing, I'm going to get the hamstrings to relax. I'm going to pull the tibia forward and then push back. Pull the tibia gently forward, push back. And as I push against the back, there should be a sudden stop as the ligament comes under tension. Relax it, pull forward, push back. Pull forward slowly, push back. And I should feel that stop as the PCL becomes tight. While we've got the knee flexed up, I'm now going to examine the joint line. So the femur comes down this way, patella's up here, tibia here, and you should be able to feel a little line, a groove that runs from front to back. Here's the patellar tendon in the front, here's the groove. Femur here, tibia here, femur here, tibia here, and I should be able to just walk my thumb right along the joint line, testing for any joint line tenderness. Then while I've got that, I'll gently twist the foot and do the same thing with my thumb, feeling for any joint line tenderness as I'm putting the knee through a range of motion. Now same thing on the medial side. Tibia here, femur here, patella here. Patella, tibial tuberosity, and I should feel a groove that runs right in here, that runs right along from front to back, and that's the joint line. So I'm going to take and gently push along here, asking her if it bothers her as I rub along. Same thing, I'll take the foot, do a little gentle twisting motion, and see if there's any tenderness along the joint line. All right, next we're going to do the torsional profile. Sarah, I need you to lay on your stomach for me. Sarah, I'm about to move the table. Don't be scared. I'm going to scoot the table over a little bit and come all the way back towards me. Perfect. So we're going to look at the rotational alignments of the leg. I'm going to bring the feet up, and we're going to first do the thigh-foot angle. So we're going to look at the line between the thigh and the way her foot sits. Now I can twist it in or twist it out a little bit either way. I want to see where it sits normally. And what we can see on Sarah is the normal alignment, and that is that she turns out about 10 degrees. So she has nice, well-balanced alignment. So her tibial alignment, her tibial rotation is normal. She has a normal adult rotation, about 10 degrees outwardly rotated. Then we're going to test her hip rotation, and part of the reason for doing the exam prone is I want the hips in extension. If you test her laying down on her back, then you're going to be doing it with the hips flexed, and we walk with our hips primarily extended. So I have her hips in extension. I'm going to gently roll her inwardly. Now this may look like outward from the back, but if you were looking at her from the front, you would call this inward rotation. So her inward rotation is about 40 degrees each. Here's 90, 20, 30, 40, not quite 45 degrees. So each hip rotates in about 40 degrees, and then external rotation, the legs form an X, external rotation, outward rotation. You can see that she rotates probably about 50, 60 degrees each way. If I want to do it exactly, then I can isolate it one at a time. So here she goes, outwardly rotates about 60 degrees on that side, externally rotates or outwardly rotates about 60 degrees on this side. All right, thank you. All right, so I've got Sarah sitting up. We're getting about to the end here. And next I want to do is I want her to straighten her knee up. Go ahead, raise your foot up, Sarah. Touch my fingers. Bring it back down. And what I've done is I'm putting my fingers right on top of her patella. Raise it up, back down, raise it up, back down. So what I'm feeling for is any crepitus, any roughness beneath the patella. So if she has any significant chondromalacia, as she straightens the knee out and pushes it back, we should feel that. This is an active test. We're actually firing her quad, pulling the patella down into the groove, and we'll elicit any tenderness. Go ahead, lift up one more time, and back down again. All right. That completes our 10-point examination of the knee joint today. Thank you very much, Sarah, for being such a good model.
Thank you.